Wound healing is a complex and dynamic process in the human body. When an injury occurs in adults, it usually leads to fibrosis and scarring, which can cause tissue dysfunction and negatively affect patients. However, during early gestation, fetal tissues can heal without fibrosis, which makes regenerative medicine an exciting field of research. Understanding the mechanisms involved in wound healing can help reduce the global burden of disease associated with it. This chapter provides a detailed explanation of the pathophysiology of wound healing, the types of healing, and how to classify wounds. Managing wounds requires clinical judgment, and this chapter offers a framework to better understand the key principles of wound and scar management. Normal wound healing in skin. Wound healing can be divided into 4 stages: hemostasis, inflammation, proliferation, and remodeling, which overlap with each other. The first stage is hemostasis, which occurs immediately after injury and involves the formation of a platelet plug to prevent further bleeding. During hemostasis, the disruption of the vascular endothelium causes vasoconstriction and exposure of the subendothelial extracellular matrix. This encourages platelets to adhere, activate and aggregate, resulting in a platelet plug. Platelet adhesion leads to the activation and release of granules containing cytokines and growth factors, which are involved in the deposition of extracellular matrix, chemotaxis, epithelialization, and angiogenesis. The second stage is inflammation, which occurs in the first 2 to 3 days after injury. Inflammation is initiated by platelet activation, which causes an influx of inflammatory cells led by polymorphonuclear leukocytes, particularly neutrophils. These cells are important for minimizing bacterial contamination of the wound. Platelets and the local injured tissue also release vasoactive amines such as histamine and serotonin, which increase vascular permeability, aiding the infiltration of inflammatory cells. During the late inflammatory phase, days 2 to 3, monocytes appear in the wound and differentiate into macrophages. Macrophages play a vital role in wound healing, functioning as phagocytic cells and releasing proteolytic enzymes to help debride the wound. They are also the primary producer of cytokines and growth factors that promote fibroblast proliferation and angiogenesis. The third stage is proliferation, which starts around day 3 and lasts for 2 to 4 weeks. It consists mainly of fibroblast activity with the production of ground substance, collagen, angiogenesis, and reepithelialization of the wound. The wound tissue formed in the early part of this phase is called granulation tissue. In the later part of this phase, there is an increase in the tensile strength of the wound as a result of increased collagen synthesis by fibroblasts. Some fibroblasts differentiate into myofibroblasts, which are contractile cells that play an important role in contraction to bring the edges of the wound together. The fourth and final stage is remodeling, which begins 2 to 3 weeks after injury and lasts for a year or more. This phase is characterized by the maturation of collagen. Type 3 collagen, which is prevalent during proliferation, is replaced by stronger type I collagen until the normal skin ratio of 4:1 type I to type 3 collagen is re-established. The collagen becomes more cross-linked and uniformly aligned, leading to increased tensile strength in the wound. The maximal tensile strength in the wound is reached 12 weeks post-injury and represents approximately 80% of the uninjured skin strength.